Franklin, do you think we should start or should we wait a few more minutes?
Oh, we can start.
Okay. Good evening, everyone. Welcome to this topic of anaphylaxis. I would like to say thank you to Franklin for inviting me to talk about anaphylaxis. My name is Jenny Smith. I'm one of the EM registrars in Cape Town, and obviously, any emergency is a passion for me. So, we talk about anaphylaxis. It's one of those very life-threatening and scary diseases that we see in the emergency unit all the way up to theater and in the wards. And with good management, we can actually treat anaphylaxis quite well. But if things go south, it goes south very quickly. So this is one of those entities where you do need a plan before like uh, before you dispose of this patient. Like you need to have a plan. Like you have to think ahead about what you're going to do for this patient before the patient actually gets to a severe point. Let me just see why I can't move my slides. So today on the agenda, we're going to talk about the pathophysiology of anaphylaxis, what the world and the South African definition is of anaphylaxis. We're going to talk about the Max McKenzie story and what our treatment will be for anaphylaxis. So anaphylaxis comes from the Greek word against protection, meaning that your immune system was exposed to something previously, and it had completely overload of your inflammatory response to this pathogen. And your body stores that information. Then whenever the next time you are exposed to overload of cascade of inflammatory response. So it's not a normal allergic reaction. It's a life-threatening allergic reaction, and it usually affects more than one organ system, as we will see in the definition. So anaphylaxis, when we remember the Jalen-Coombs criteria, it's a type 1 hypersensitivity reaction, meaning that it's IgE mediated, the response. There should be some form of mast cell degranulation, and that causes the activation of your inflammatory cascade. And one of the many things that happen is histamine release. What causes anaphylaxis? So in children and young adults, food is the most common cause of anaphylaxis. And among these food allergies, nuts, fish, and shellfish are the most common causes of food allergens. On the adult side, not so much food, although food is there, but medication is more common to cause morbidity from allergic reaction like anaphylaxis. So it's usually your beta-lactam antibiotics, your NSAIDs, especially your non-selective COX inhibitors or your COX-1 inhibitors like ibuprofen, your muscle relaxants, any muscle relaxant, not just succinylcholine. It can be rocuronium as well, um, uh, one of the adverse effects of rocuronium is a hypersensitivity reaction and IV contrast, although it's not seen so commonly anymore because of all the new contrast we are using, but old IV contrast can still cause an inflammatory reaction leading to anaphylaxis. And then in 30 to 60% of cases, we don't even know what caused this anaphylaxis, and that's usually classified as idiopathic. So after this life-threatening disease has happened and you stabilize the patient, 30 to 60% of patients won't even have a clear reason as to what caused this anaphylaxis trigger. Then there's three other things that we need to remember about anaphylaxis. The thing that scares most people is the biphasic reaction. This means that you can have a similar inflammatory or allergic reaction in up to 20% of patients within 6 hours of presentation of the initial anaphylaxis reaction. There's usually about three risk factors that will keep you or to risk stratify your patient as to if this patient is going to be a patient we need to consider biphasic reactions on. And then it's usually a patient that gives you a previous history of anaphylaxis, a patient that like falls in the idiopathic allergy or idiopathic trigger block where you don't know what the trigger was, and if there was a delay in adrenaline administration of more than an hour after symptom onset in the current presentation. And we must remember that anaphylaxis, although we've always thought of it as a distributive type of shock, where you have capillary leak and a fullness of your vascular reserve. But at the end of the day, it's actually more like septic shock. It's there's some cardiogenic involvement from your inflammatory markers. There's hypovolemic shock because of the capillary leak and the third spate losses that happens. And obviously, there's this distributive shock component to it. So that's why it's not just distributive shock, but it's really a three parts of shock. And once you understand that or appreciate that, you can understand why these patients go south very quickly. And then this likes to come up in tests, especially MCQs, what the difference is between an anaphylaxis and anaphylactoid reaction. And an anaphylactoid reaction looks exactly like an anaphylactic reaction. The origin or the pathophysiology behind it is just a difference. So anaphylactoid reaction is a non-IgE mediated reaction. So it means that you or the patient wouldn't have had a previous exposure to a antigen to make antibodies like the IgE to react, in a anaphylaxis type of way. And the most common example will be snake antivenom. Like no one has usually had previous exposure to snake antivenom. Then when you give the snake antivenom, they can have an anaphylactoid reaction. And in the clinical setting, it's not really that important to differentiate between the two because both of them are treated exactly the same way. But it's like I said, it does come up in theory papers. And the other example is aspirin-induced bronchospasm. It's an anaphylactoid reaction. It will always happen um, with if someone is more prone to having anaphylactoid reactions. So this is the World Allergy Organization, the definition from 2020. They haven't sat again to make up a new definition. So we follow this World Allergy Organization definition. It breaks it down to two. So you must have one of these two scenarios. There must be acute onset of some airway involvement, airway or breathing involvement, or circulation involvement after an exposure to a known or highly probable allergen for that patient. So if a patient comes to you and the mom says the child ingested something that contains nuts, or you went to Ocean Basket and the child ate some of the prawns from his dad's plate, then you must know that it's probably an allergen and it could be the cause of this airway breathing or circulation problem. And we treat that as anaphylaxis. Or you can have a patient with acute illness that involves one or more organ systems, but with no known or highly probable allergen exposure at the beginning. So you need one of these, and then you need one of these. So you will need some respiratory, so airway or breathing impairment. You need some circulatory impairment or some GI symptoms. And it can be very, very subtle. It can literally be a skin rash and vomiting. And that is enough. With a history of allergen exposure, that is enough to make a decision that this patient has anaphylaxis. Coming back to South Africa, what do we look at? So this is directly from the Resuscitation Council guidelines. And you can see here at the top right, it was updated this year in 2025. And you can see it's been endorsed by Allergy Foundation South Africa, the Allergy Association of Society of South Africa. So this is a very rigid and common anaphylaxis protocol that we need to look at. And you can see here, they look at almost the same thing. So they say that if you have a patient with skin involvement, plus a airway, breathing, or circulation compromise, or you have a patient that has a history of an exposure to a highly probable allergen, like in the previous definition, with breathing or circulation compromise. So to note, no need for skin or mucous membrane involvement. So respiratory compromise plus exposure to a probable or known allergen is enough to make the diagnosis of anaphylaxis. So the Max McKenzie story, I don't know how many of you have read up about it, but it's this 15-year-old boy, Max, and his father is actually a emergency physician in Australia, Ben McKenzie. What happened was that Max was visiting his grandmother, and she gave him something that contained, he had a nut allergy, and or a tree nut allergy, and she gave him something that, like a fudge brownie with walnuts in it, and he started having this anaphylaxis reaction. They rushed him to hospital, and what happened there was Ben, the father, thinks that the healthcare providers that looked after his son did not do enough, or they were not acting fast enough to be able to save his son. So Max sustained a hypoxic brain injury. There was They took very long to intubate him, and that was very difficult to intubate because at the time where they tried to intubate Max, he had a lot of swelling in his airways. It was a difficult intubation. The most senior person was also not intubating on the floor, and they did not follow a anaphylaxis protocol. So that's where, or they also didn't think about the front of neck access. So this is where this AMAX, 4MAX, comes from. This is now Ben McKenzie and his wife trying to raise awareness as to what can we do to prevent people like Max. Max sustained a hypoxic brain injury at the end, and he died 13 days later uh, after this anaphylaxis episode. So it is sad, but it is the truth. I'm sure there's many more other children and adults that has died because either we didn't see or made the diagnosis of anaphylaxis, or we didn't have a plan as to how we're going to go about treating these patients. So the bottom line of this whole story and the whole talk is time to brain injury is extremely short. It takes 4 minutes for your brain without oxygen to start developing a hypoxic brain injury. It can be something small and it can lead to something bigger. And CPR in a hypoxic arrest is not going to extend, it's not going to buy you time. It's not going to extend your brain perfusion because these patients do not have a functional residual reserve left. So CPR might bring a blood supply to the brain, but it does not necessarily bring oxygenated blood to the brain. So hypoxic cardiac arrest is quite different to a normal cardiac arrest or witnessed cardiac arrest that you see that happens in front of you from VF. So this is my proposal that we have a plan for the responsive and the unresponsive patient. And usually we get tested on the responsive patient. But people like Max and many others, you'll see when you read up about this, there's a lot of other patients that have gone the similar route to Max. And so we need to also have a toolbox for the unresponsive patient when they come in. This is directly from that Resuscitation Council of South Africa's anaphylaxis protocol. The second point after you've made the diagnosis in the responsive patient is to give adrenaline. Always adrenaline. Nothing else but adrenaline. Adrenaline will change and reverse and buy you time for every part of the anaphylaxis, like the airway. It will prevent or slow down deterioration of airway swelling. It will increase your breathing, decrease your work of breathing, increase your, it will try to reverse your bronchospasm. It can also help with your circulation by increasing your vascular tone. So, adrenaline is the mainstay of treatment for anaphylaxis. There's nothing else. Um, at the beginning, we don't grab steroids, we don't grab antihistamines. This is what saves people is adrenaline. And if you can't remember the 10 mics kg, you're there in the middle of that, adults get 0.5 moles of clean, straight adrenaline from the ampule. Children get 0.3, infants 0.15. And this is just the auto injectors. This is how much adrenaline is in one of those auto injectors. Just remember the auto injectors are quite expensive. They usually expire in 1 year, and you need good education when you have one of those EpiPens, or there's a lot of other ones on the market nowadays. So whoever keeps the injector must know how to use it, and the caretakers and the school teachers also must know how to use it. But it's easier just to draw up 1 amp of adrenaline. I mean, it's so cheap compared to what the EpiPen costs. And you can see there the indications for adrenaline is for your airway, breathing, and circulation, or if you think that two organs are involved. And like I said, it can be literally subtle, like a vomiting and urticaria, and then you have anaphylaxis. You can always give the first dose of adrenaline, but omitting the first dose of adrenaline, the patient will become from a responsive patient to an unresponsive patient. Going on to the responsive patient, after you've given your adrenaline, now you start with your supplemental therapy. So you give oxygen, you try to maintain the airway, patency of the patient. If you think that this patient needs an intubation, if you think about it, the patient probably needs an intubation, and you need to get ready for that intubation. Remember that your first chance should be your best chance. So you get the biggest plate you can get, you ramp up the bed, you make everything as comfortable as it can be. And if you feel like uncomfortable intubating this patient, this is not a time where you try to let one of the students intubate. This is now where the most senior person on the floor tries to intubate, because time is of the essence here. You have to prepare for a difficult airway in these type of patients. Usually, I know in most of the EDs, what they do is they do a double setup. So if you're going to do intubation, someone else is getting ready with a airway or front of neck access. Um, how we're doing it is beyond the scope of this lecture, but you can read up about what your approach would be. So whoever tries to intubate from the top, they have one go at it, one attempt. And if they fail, you go over to the front of neck access or the surgical airway immediately. This, and it must not be the same person. It must be someone else that has already been like prepped on the neck side, knows where he's going to go in, has cleaned the area, and as soon as the normal conventional intubation fails, you go for front of neck access. This just helps to decrease the cognitive load on the person that is intubating, and also it buys you time. You don't waste time by trying to go for multiple intubation attempts, and if the patient ends up with having a hypoxic arrest and you don't have a airway or a definite airway, and you sit with a can't intubate, can't oxygenate situation. Remember to give high flow oxygen, put on your monitors, your 3-lead ECG, your SATS probe, and your BP cuff. Very important, and we're gonna um, touch on it again. It's very good practice not to keep your BP cuff on the same side as what your line is. Ideally, with like two lines type of patients, but if you only have one line, don't put your BP cuff on the same side, because the medication you're going to give, like adrenaline, can tissue, and it can really cause detrimental side effects. And if you inflate your blood pressure, that medication does not go to the rest of the body. So just putting the BP cuff on the same side, I'm sure anesthetists will tell you that it's not good practice to do that. And you remember time is money here. So you would like to try to get that medication to the heart and to the rest of the circulation as soon as possible. And positioning is very important. Remember, this is a type of distributive shock. So there's a lot of vasoplegia. So a lot of your venous reserves are full of blood. So what you can do is you can try, if the patient doesn't have an airway or breathing problem, if he only has a circulation problem, you can lift up the legs. That will help you to get a bit of venous return. If the patient cannot cope with lying down, you can put them in a seated position and a phallus position, but don't let the patient stand. That just that you worsens your distributive shock. And if it's a pregnant patient, you can put the patient in a left lateral position, especially if they're over the age, over the gestation of 20 weeks. Just remember that adrenaline, there's no contraindication for adrenaline in anaphylaxis. If you are pregnant, it's not a contraindication for adrenaline. Adrenaline saves lives. So this is the fourth part of the anaphylaxis algorithm, the South African one, for the responsive patient. So this is now your secondary stuff that you do. You have given adrenaline, you have done your supplementary oxygen, you've put up a line. Now you give fluids because we know there's a component of hypovolemic shock and also distributive shock. So you start your 20 ml per kg bolus. If that doesn't work, you can give another 20 ml per kg bolus. Try to target a systolic blood pressure of 90. Just, I mean, it's very arbitrary. We don't have to remember exactly 90 systolic BP. Some patients, a 90 can be very high or very low. So look at your patient. Is your patient's level of consciousness improving? Is the capillary moving centrally? You know, if the patient starting making urine, if you have put in a transurethral catheter. Then if it's a wheezy patient, you can give nebulized bronchodilators and you can give that every 15 to 20 minutes as if you would in a asthma patient. So the, the anaphylactic patient really looks the same, especially if there's airway and breathing components to it. And you can give salbutamol 5 milligrams. That's usually a normal salbutamol ampoule. Or if you have access to phenobarbital, you can give that with some program. So most of us that work in the public sector, it will be AB meds, so our salbutamol and ipratropium every 15 to 20 minutes. Then you can start an adrenaline infusion. So this is considered refractory anaphylaxis. Is if you have given 2 doses of adrenaline, IMI, 5 minutes apart, and the patient is still not responding. We need to start an adrenaline infusion. And we'll go into it a bit later, but we should start at the normal 0.1 to 1 mics per kg per minute, and you titrate it up according to the response of the patient. You give glucagon. They've added glucagon to the anaphylaxis algorithm because it could be that you're actually not dealing with anaphylaxis, but with a beta blocker overdose. And or if a patient is on beta blockers and they are not responding to the adrenaline you gave them, then you can give them glucagon. You can give it every 5 minutes at 20 microgram per kg. And this will just, how glucagon works in the patient that's on beta blockers is glucagon doesn't follow the normal adrenergic pathway to increase the contractility of the heart. It actually directly binds to glucagon receptors, and that increases the cyclic AMP in the myocytes. That increases the calcium influx and causes the increased contractility in the heart. So it's a non-adrenergic way to inotrope. But it only works if your patient is on some sort of beta blocker, like a beta blocker overdose, or the patient is on a chronic beta blocker. I forgot to say at the beginning, yeah, under adrenaline, where do we give the adrenaline? So if you don't have a line up, you give it in the anterolateral aspect of the thigh. They've done a lot of studies to see where is the best place to put or to administer this adrenaline. Should it be in the deltoid? Should it be in the buttocks? Or should it be in the thigh? And it actually showed that you get best success, especially in these patients that are now shutting down in the lateral thigh. So for adults, for children, for infants, whatever you are dealing with in the anterior lateral aspects of the thigh. It's a big muscle group. There's not a lot of soft tissue in that area, and there's a lot of vascular blood supply there. So what about antihistamines and steroids? You can give it, but you don't give it at the beginning because there is no evidence to show antihistamines and steroids help in anaphylaxis. The mainstay of treatment for anaphylaxis is adrenaline. Adrenaline for its inotropic support and all of its other benefits, and also fluids. That's what you do. There's no role for antihistamines and steroids. It doesn't even it hasn't even been shown to prevent the recurrence of a biphasic reaction. So there's really no role. It does help for symptoms, like if the patient came in and they are itchy, you can give antihistamines, but it's not going to improve your anaphylaxis. So don't bargain on these drugs and start throwing everything but the kitchen sink to these patients. These two drugs are not going to improve your outcome. So now it's all good and well if everything goes well. The patient comes in, he's hypotensive, he has urticaria, you give him one dose of adrenaline, and he's better, and everyone's so happy. You were nipping, but now you're not nipping anymore because the patient has improved. But unfortunately, we do get cases where there is a refractory anaphylaxis, and this is where things go south, and they go south very quickly. So this is by definition, this is when you have given two doses of IMI adrenaline, 5 minutes apart, and there's no improvement in that patient's symptoms. So then you do need to put up an IV line if you haven't done so already. You have to start your adrenaline infusion. You can go up to another second and third 20 mils per kg IV crystalloid fluid bolus if you haven't done that already. And you can also give glucagon if you think that this patient is probably having a beta blocker, calcium channel blocker, or overdose, or just having it's an elderly patient that's on a beta blocker for their AF or blood pressure. And also try to optimize the administration of these drugs. Maybe it's not the adrenaline itself that's not working. Maybe it's the adrenaline not getting to the heart. So do not piggyback this infusion onto your IV fluids. Give it straight into the cannula. Rather put up another line. I know it's not easy. If you don't have another line, rather give the adrenaline uh, and then the fluid on top of the adrenaline and not the other way around. And like I said, please don't put the BP cuff on the same side of the IV line. If the adrenaline can extravasate and it can cause a lot of side effects for the patient, or it can just not reach the rest of the heart and the rest of the body, and then you say that this patient is in the refractory anaphylaxis, and that patient will not even respond to adrenaline infusion as well. So that is my take on the responsive patient. Adrenaline, go on with adrenaline, do your supplementary oxygen and monitoring, positioning, and then look out for refractory anaphylaxis. Now coming to the unresponsive. I see there's a hand.
Hi, Doc. I just wanted to know if the IM dose is 10 mics per kg, and let's say we have the patient and they already have IV access, is the IV dose the same?
Yes, correct. So if you have a patient, especially a patient in the ward, the patient already on the table, and you need to give adrenaline, it would be the 10 mics per kg dose if you already have a line. and you know that that line is working. If you think that that line is suspect, then rather give the IM dose. Does that answer your question?
Yes, thank you.
No problem. Okay, so coming to the unresponsive patient, this now like Max. Patient comes in unconscious, needing assisted ventilation, and they include asthma here as well. So the crashing asthmatic or the anaphylactic patient are both treated the same way. So what we do here is we go max. So the A is for adrenaline. We give a 1 mic per kg IV push of adrenaline, or you can just give the cardiac arrest dose, which is 10 mics per kg. But it does help to rather give IV pushes, because you'll see if you give too much adrenaline, you'll start having tachycardias and all the side effects of adrenaline. And, um, you know, then you have to wait 4 minutes for the adrenaline to work out before you can titrate your adrenaline. So rather give small dosages. So how do we mix up this? Everyone does it differently, but this is easy for me to remember. So I take 1 amp of adrenaline, which is 1,000 milligrams, and 100 mils a crystalloid of normal saline. And if I put my 1 amp in there, that should give me 10 mics per kg. I know a lot of other people take the 1 mics of the 1,000 milligram of adrenaline, mix it with 10 mils, and take 1 mil of that and put it in another 10 mil. It's just like, I feel like, then you have two syringes. If you don't mark it, no one knows what you're talking about. This is very easy to do. So if you don't have 100 mil, and you only have 200 mil saline vacuolators, then you can put 2 amps in there. If you don't have 200 mils, if you're fancy and you have 50 mil vacuolators, then just go half of the ampule of adrenaline, and that will give you your 10 mics per kg, and you adjust the dose to 1 mics per kg of the for the patient that's in front of you, peds or adults, doesn't matter. Then use a muscle relaxant. Don't try to intubate a patient that is crashing in front of you, that does not, they are trying to fight for their lives, and they are advocating in this AMAX 4 um, protocol for rocuronium, just because it's easily accessible. It does take some time the onset takes some time, can take up to 1 minute, but you have a patient that has relaxed for quite a longer time than just succinylmeconium. So think about the muscle relaxant, especially if you have this patient that's quite tundent, fighting you. And remember, we're giving the highest dose of our muscle relaxant because we have a hypotensive patient. So 1.2 milligrams per kg IV. And then the A max, the second A is for airway. So this type of patient must have an endotracheal tube. This is not the time we put in an LMA or bag mask, because this patient has high airway pressures. We know that if you have breathing or airway involvement, there is probably bronchoconstriction and all of the sequelae. So your peak airway pressures are going to be high, can be 50 up to 100. So in order to accommodate for this, you need a secure, definite airway with a cuff. That also reduces your aspiration risk, especially if the patient this patient is unresponsive. He is a high, or she is a high aspiration risk. And we need to be ready to do a front of neck access if we get into the can't intubate, can't oxygenate situation. And they say or advocate that we should try to go for front of neck access after your first attempt. And I think it's fair. I think it's fair that we need to try to go for front of neck access after one attempt of airway or normal conventional intubation. And they also say practice make perfect. This is also not the time where you do your first front of neck access. They say that you need to do some simulations, or you need to talk about it. And you know, I know for most of us, this is probably the one time that you're going to have to do a front of neck access for upper airway obstruction. But try that this is not your first attempt, like you have thought about it in your mind, you have done some simulations, you have some sort of checklist, so that if you get to this point, you know what to do and you don't freeze or stall, because the front of neck access is what's going to save this patient. And then we get to the excess, the extreme ventilation, extreme bronchodilators, extra vasopressors if necessary, and think about a pneumothorax. So our maximum intervention is going to be ketamine. We're going to try to use ketamine because we know it has a bronchodilator effect. It also more cardiovascularly stable than most like propofol, other induction agents. We are going to use extra bronchodilators. We're going to use salbutamol. Obviously, if you want to use bronchodilators after you've intubated the patient, you need some sort of in-circuit device to do this. And when you do, you can use salbutamol and hypertropium over 1 hour as a continuous stabilization. You're also going to try other options. If you do have inline nebulization devices available, you can try IV salbutamol. You can start at 10 to 15 mics per kg as a loading dose, and then you can titrate. Start with 5 mics per minute, increase by 5 mics per minute to a maximum of 20 mics per minute. You can also give magnesium sulfate at 40 milligrams per kg. They say can go up to 75 milligrams. But remember to give it over 20 to 30 minutes because it does cause hypotension in itself, especially if you give it fast. But you'll see if bronchoconstriction was the cause of your hypotension, then and you know that positive airway pressure and high mean airway pressure, you'll see that giving the magnesium sulfate will actually increase your blood pressure because you have relieved the cause of the hypotension. And you can definitely think of things like noradrenaline or phenylephrine if you have access to it. And this is not the time where it's because it has proof that it does prevent or it changes or decreases your airway swelling, and it does help in the long term to reverse that inflammatory response in your airways. So definitely a role for steroids when it comes to the intubated, unresponsive patient, crashing asthmatic or anaphylactic patient. Just remember the max dose of hydrocortisone is 400 milligrams, and the max dose of dexamethasone is 8 milligrams, according to this protocol. And the 4 is to remember that it was 4 max, but it takes 4 minutes to cause a hypoxic brain injury. So in conclusion, anaphylaxis is a life-threatening condition. The only thing that can help you is adrenaline, and you have to have a plan or a toolbox for your responsive patient and your unresponsive patient. And remember that if you get an unresponsive patient and you think things are going off, you use extreme measures to get you out of trouble. Yeah, and that's it. Any questions? I did